Welcome to the Wealth Podcast, Off With Your Coat, a podcast on women's health and wellness where we flip the script and ditch the surface level chatter. We need to ask the real questions. Let's get back to storytelling and back to basics to help us uncover how to set ourselves up for true health and wellness and pass it on. I'm Kat Duff, founder of GenWell, the women's health advocacy brand building wealth, the intersection of health and wellness. Some days it's me and a doctor, coat off, talking about what really matters. No fluff, no filters. Other days, it's East meets West, trading tools, not punches, to help move women's health forward. We're building generational wealth. Come with us. Coats off, let's go. Understand function, strength, and sex. PBUFFS. Y'all remember PEMDAS, the order of operations in math? Well, today we're diving into the pelvic floor, and I want you to remember PBUFFS. Pelvic, babes, understand function, strength, and sex. Got your attention? Whether you've had kids or not, whether you are 25, postpartum, going through IVF, dealing with constipation, taking a GLP-1, having painful sex, or think your pelvic floor is totally fine. Or perhaps you're like, what is my pelvic floor? This episode is for you. Today, I'm joined by Dr. Alicia Jeffrey-Thomas, pelvic floor physical therapist, author of Power to the Pelvis, and founder of the Pelvic Dance Floor, to talk about what your pelvic floor is actually doing, the signs that something might be off, and how to advocate for better care before you're dealing with a bigger problem. We get into everything from peeing, pooping, and prolapse to sex and orgasms and some of the biggest pelvic floor advice and myths taking over social media. And maybe most importantly, why pelvic floor care should be a part of preventative health. With that, off with your coat. We are so psyched to have Alicia here. So Alicia, welcome to Off With Your Coat.
Thank you so much for having me.
So I was thinking about, this is going to come off weird. I was thinking about you on Friday because I went to P-Town and for our non-New England friends, Provincetown, for the first time. And we stumbled upon multiple sex shops. And so I had very many a question about what was happening. My favorite device looked like some sort of octopus tentacle.
Cool.
But there's such a connection between the sexual health, all of these devices that I want to get into later, and a lot of the things I was looking at. So that was my weekend, just, exploring sexual health, all the good things. Well, I wanted to jump in how we always do and kind of get under the hood with you, and wanted to know just what was something in your health journey or your studies that it was really an aha moment for you that you were just like, what the heck is going on in women's health?
So I think honestly, this ties into what brought me into pelvic PT in the first place. So I was raised in the deep South, Bible Belt South. Our sex education was next to non-existent. It was very shame-based. It was very you pass the crumpled piece of paper around the room type of thing. And I think, the aha moment for me was the first time that I really shadowed a pelvic floor therapist. And, it was getting to see the therapist in action, educating this fully grown woman about her body and, kind of demystifying things that you would think now for me are so common sense, but, it's you don't realize how many holes you have. You don't realize, how the muscles down here are tied to so many of life's most basic functions. And so really it was just kind of this moment of, this is an area of medicine that I can be a part of to help to bring this kind of empowerment to other people.
Yeah. I mean, how powerful is that to not grow up with any of that and just be immersed in it? I mean, but I think that's a common story, right? We don't have any body literacy.
I mean, and I would say it's definitely a contrast moving up to New England and seeing the fact that we're surrounded by people who have more education about their bodies. But even within this environment, there's still, big gaps, I feel that we run into where, stuff has just seeped through the cracks. And then I'm, again, educating people in their 20s, 30s, 40s, 50s, 60s about something that should be taught when they are getting their initial, this is what happens to your body in puberty type of education.
Yeah. What have you been seeing in clinic and practice that a vast majority of women are coming in with that is just not talked about enough?
I mean, I think it's, to me, because I get into the nitty gritty of how people are, going to the bathroom and things like that, right? Like it's, the people who have normalized spending tons of time on the toilet to go to the bathroom, right? And they, or they feel like everything that has to do with that area has to be painful or difficult or, this like not natural, easy process. And I think a lot of that has to do with the lack of information. I think a lot of that has to do with just the stress and the rush of day-to-day life. And all of that kind of comes together in this cumulative thing where we're having a lot of dysfunction across the board.
Yeah. Well, let's just dive right into that because you wrote an incredible book called The Power to the Pelvis. I know you touched on a little bit of your interest in that area, but I love it because it's sort of that like choose your own adventure type of book where you can kind of go to any page and teach yourself, if you're a clinician, understand a better way to communicate with patients. How do you hope that women read this book and can start to learn about their bodies from like the get-go?
Yeah. I mean, I think that some of this comes from, at these touch points in healthcare where somebody might realize that they have a urinary incontinence problem or a pelvic pain problem. They might not feel that they're equipped with the language to describe what's going on to their provider, or they might feel like they're going to get dismissed if they do bring it up. I want this to be a resource that serves to empower them not only to have things to start working on their own, but also to then develop that language and have a little bit more information to share with that provider and how to get to those next steps so that they can get treatment.
And how about you? How did you, like from your studies and then taking care of yourself, like what has your pelvic floor journey been?
So I was kind of the chronically constipated kid.
Yeah. Right.
And, I always joke that I think my mom should have been the inventor of the squatty potty because she was always the one saying like, turn the trash can on its side, put your feet up, like there's things that I feel like we figure out and we know, even if we don't know. But I remember kind of putting that together when I got into my pelvic floor clinical rotation, when my clinical instructor, Vicky, was like, yeah, there's a squatty potty in the bathroom. Like, you should go try it out. This is why it works. Da, 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 da. And then kind of layering that in with, education about diet and the nervous system and all of these things and how they all kind of work together. It was this moment of like, wow, I'm 25 and I know how to poop now. Like, congratulations to me.
That's like 10 years, earlier than me. So that's amazing.
Of the curve,
You are. Well, I feel like all of my friends, myself included, I feel like women are there is a chronic constipation issue. So how do you know if it's a pelvic floor issue? How do you know if it's fiber intake? Or how do you just work with other providers or empower women to like sift through all of that?
Yeah. I mean, so you can define constipation in a bunch of different ways, right? It can be from a frequency standpoint, like, hey, you're going fewer than 3 times a week, And so in that case, maybe we're talking about what can we do from a physical activity standpoint or a abdominal massage standpoint, or maybe we have to, talk to somebody about some kind of medication to help to move things along through the system. But then I'm asking all of these questions. I'm asking about the stool type itself, right? Like, is it hard? Is it loose? Is it skinny? Is it wide? Different things like that. If, we need to change something fluid wise, dietary wise, I can start to give recommendations there. I can refer out to a dietitian. It becomes a very collaborative process. Where I'm, fairly certain that it's a pelvic floor issue is when we're having kind of difficulty passing the stool, right? If we feel like we're pushing and pushing and pushing and nothing's coming out, or your stool is coming out really skinny, or you have that sensation of, you didn't quite get it all out, or the Parks and Rec reference of you feel like you're wiping a marker, like you just can't get clean after. That to me is signaling that something is not properly relaxing in the pelvic floor.
And so it would be a tight pelvic floor, not a weak pelvic floor?
Typically, yeah. I mean, the other thing that can happen is if somebody develops a rectocele, which is basically a type of prolapse where the rectum pushes into the vaginal canal, you kind of can get this like poop pocket. And so part of the reason, delightful things that you find out in pelvic floor therapy. But, it's basically, there's this pocket that stool can sit in. And so you have the sensation of stuff's not coming out, but like that might have been from a weakness issue. That might have been from a tension/weakness issue. We're pushing wrong. We're, doing all, different things we're pushing wrong. We're, doing all, different things like that. So that's where, getting the assessment and seeing what's happening with the muscles is really, really key and really, really important.
My mind just went to like endometriosis. Do you work with a lot of women that have had endometriosis surgery or that maybe don't know that they have endometriosis? And does that affect like if they have bowel endometriosis or any of that?
Definitely. I think, that's been kind of one of the big pieces that people are finally starting to talk about more. There's, a lot of the IBS girlies, right? Where it really ends up being that there was, endometriosis around the bowel that was contributing to a lot of this pain and a lot of this difficulty with bowel movements. So certainly I see a ton of people who are either planning to have endosurgery or have had endosurgery. And we're looking to kind of, make sure that we've retrained the system, because if you've been having this dysfunction chronically for so long, yes, maybe you took out the endometriosis, you took out the disease that was driving that issue, but your muscles and your nervous system have kind of learned to be in this one state. And so we have to retrain them how to do it properly.
A quick note on retraining the system. So talking about the healthcare system, is there anything that when you're having patients referred to you, is there any one thing that you think you wish clinicians would be asking women before they get to you or they hopefully get to you?
I was going to say, here's the thing is if you get them to me, great, we can figure it all out. I would love it for their own understanding if they just asked more questions. But, if they get enough that they can refer them to me, if we're screening for any type of urinary dysfunction, bowel dysfunction, sexual dysfunction, pelvic pain, if they're saying yes to any of that, get them to me and I will figure it out. We will get into the nitty gritty and I will ask the questions in a way that makes sense to finding solutions for them.
Why do you think it has not historically been a part of preventative care?
It's a really good question, right? Because there's other countries like France where it's kind of ingrained into their system to, I think you get somewhere between 6 to 8 guaranteed postpartum visits in France with a pelvic floor therapist or a midwife that's doing pelvic floor work.
That makes me wet to think about.
Right.
Honestly, you're like, what? That's amazing.
Why is this it's there and it's been there for decades? And how have we not picked up on that? I really think that this should just be part of the conversation in the same way that they're hey, we have a lactation consultant, we have a this, we have a that, and pelvic floor therapy, right? That should just be in that conversation. And I don't necessarily know why that is. I think I can hypothesize reasons, right? People are going to decide that, well, what I worry is that sometimes the providers that would refer them are kind of making assumptions about they're not going to have time because they're going to be a new mom, or they, their insurance might not cover it. And I want, if anything, if any providers are listening to this, take those assumptions out and give people the information, let them know that the resource is there and let them decide what they want to do with their time and money and whatever. Because for some people, this is going to be a big enough impact on quality of life that those things aren't going to matter. They're going to make it work, but they can't know that it's an option unless somebody tells them.
And also if you haven't had a child or you haven't had a kid,
for sure.
And also if you're a man.
Yeah. Literally anybody, any age, any gender, you all have pelvic floors. You can all have pelvic floor issues. There are pediatric pelvic floor therapists that exclusively work with kiddos with bedwetting and constipation issues and giggle incontinence and things like that. There are, pelvic floor therapists that work with people, adults across the age and gender spectrum, for pelvic pain, for all of these things. Regardless, it's not just you've had kids and you need pelvic floor therapy. Anytime, any place, there's no time too young or too old. I've also seen people that are, in their upper 90s that are still getting benefit from pelvic floor therapy.
Is there a target age for girls that you think if you were to wave a magic wand or change the system that you're okay, this is the age preventatively that girls should be seeing a pelvic floor therapist?
I could see a world in which having a, kind of preventative screen somewhere in their early to mid 20s would be awesome, right? Just to learn about what their body's doing and be able to answer any questions that maybe they haven't felt comfortable bringing up, because I'm going to sit there and I'm going to go through like, hey, does it hurt when you have sex? Does it, do you feel like you have to push your pee out? Like all these questions that your average GP appointment or OBGYN appointment isn't necessarily going to get into. And then we can identify issues earlier, before we, if we decide that we're going to have kids, we can start to kind of pre-solve those things. Before we start to have major hormonal shifts around perimenopause, we already have that kind of bodily awareness of like where to anticipate things. So I do think an earlier touch point, just a one visit thing, if that's all you need, but just, to know what's going on would be awesome.
I think in the context of my daughter, I'm like, how do I empower her, like you were doing in the book, to have body autonomy, to understand what's happening? Like, I'm almost wondering, like, would it be beneficial when she's 16 to have someone like one of your colleagues gave me a mirror and was just like, I'm going to walk you through all of your tissues. Here's the vulva. Here's what's going on. Here's your clit. Like, here's your clitoral hood. I'm like, how am I 39 and I didn't know that my clit had a hood and what is it doing? Like, what?
Right.
What?
Right. Yeah.
So that, like, my mind is like, okay, how can we empower the next generation? Like, should it be younger in a way that's comfortable and empowering versus like, I think also it helps us to take the taboo and stigma out of it, right?
Yeah, no, absolutely. Right. And I don't want it to be, I mean, I have always thought that it's a little bizarre, right? That like your first like pap smear, is this like, oh, okay, we're not even just starting with like what's happening external. It's like, we're going in, right?
We're going in.
Like, I think you're right, like an even earlier touch point to say, here is your anatomy, right? Here is how it relates to these bodily functions. Here's how if something is, outside of what it should be doing, right? And having them being able to identify that earlier and reducing shame and reducing stigma around it, I think would only serve to, help people live, more fulfilling and enjoyable lives.
Well, yeah, and the fulfilling and enjoyable part. I mean, think about my mind went to in my 20s. I'm like, how much better sex could you have been having if you knew that your clitoral hood was
if your clit
stuck?
had a hood, yeah.
Right?
Yeah.
So, and for our listeners, like in order to get to the clitoral hood, maybe let's backtrack and just talk about the pelvic floor for a moment. So
Sure.
It's obviously the basin. Like I always think of it as like, because I have a little bit of TMJ and jaw issues, and they've like gone away pretty much completely since I started pelvic floor PT. So talk to us about like where the pelvic floor is with your spine. What's like the quick and dirty 101 that we all need to know?
Sure. So your pelvic floor is basically
I love a little. Yes,
I'm like,
please.
I always have a visual on hand. Your pelvic floor is basically usually described as a hammock or a sling of muscles, right? So it's going from the pubic bone in the front up underneath, crossing your opening for your urethra, your vagina, your anus, up to your tailbone in the back. So it's basically acting as that support from the bottom, as well as that sphincteric opening and closing type of support. It's responsible for working with your core for core stability. It helps to manage pressure. It has a bunch of these, really good, really important jobs. And like we said, because it attaches to things like your tailbone, it can then impact what's happening with your spine. I've seen a lot of people where their back pain, hip pain, are kind of like not responding to typical treatments. And it turns out that it's coming from their pelvic floor. So
yeah. That was like 100% the case for me. I've had this like chronic lower back pain. Really, it started, I've had hip pain since I was younger. I remember playing sports and like having to go in and getting like stim pads on my piriformis, like in high school or something.
Yeah.
And it probably was pelvic floor issues related. And so now that I've gone through PT, it's like that pain. Like, we'll talk about the internal massage in a moment, but like it is life-changing to just address that muscle sheath. It's wild.
Yeah.
So talk to me a little bit about the mnemonic that you created. So like sort of the PEMDAS for the pelvic floor.
Yes,
and like
the PBUFFS. Yeah.
Yeah. Like, yes. So I also, I'll give you my take on a minute on something that I I've created for you. But
Cool. Excellent.
yeah, talk me through what it stands for and what it means for the pelvic floor.
Totally. So, right. So we have PEMDAS for mouth, we have PBUFFS for the pelvic floor. And this is not something that is like written up in literature. This is purely exclusively how I have kind of seen things in clinic, right? So there's like an order of operations where if you're coming in with multiple issues, where do I expect to start to see changes first, right? And so for that, usually I kind of start at the top with pain. Because if there's pain, if the nervous system is upregulated, that's going to make it really hard for everything else to kind of fall into place, right? Like, I see this a lot with people who have like painful bladder syndrome, right? I'm not going to be able to like train away, urinary urgency and frequency if every time your bladder fills up, it feels like you're being knifed in the gut, So we have to address the pain side of this first. And then usually what I'll do is I'll jump to bowels because I kind of consider this like the theory of stuff. There's only so much room in your pelvis for everything to coexist. And if you are full of poop, then that's going to be putting pressure on your bladder, on your other pelvic organs. It's going to be creating discomfort. So we're addressing constipation second, right? Or whatever bowel issue is present. And this is, it's kind of layering in with if you had pain and you had a tight pelvic floor, you have constipation, maybe from a tight pelvic floor. Like they're all kind of starting to follow each other, and then we can kind of get into some of the urinary symptoms. So like being able to manage, severe urges when they happen so that you don't feel like you're going to leak or that you're running to the bathroom, and then frequency. And then we can kind of see more responsiveness to stress incontinence, coughing, laughing, sneezing, running, jumping. Those kind of tend to come like right after. And then after all of that, like once everything is like, wow, okay, cool, we've like got it. Then we can start to see, more of that like sexual function stuff start to improve. And I really honestly, the best understanding of this is usually when I see a guy who has had a prostatectomy, right? Because they're, newly post-op, right? And so they have maybe some post-surgical pain. They have constipation from, having to be on pain medications. But they're telling me like, hey, like the big thing is that like my pee, man. And I'm like, yeah, I know, but we have to get through all of these other things in order to get to that. And then, the other thing that they bring up maybe on like the third visit is, oh, right, I also want to be able to get an erection. And I'm like, yeah, we'll get there. It's just we got to get everything else, kind of into the game together.
This is a wild comment, but I was thinking of the order of operations and like what you were saying about space in there. And then that sexual health is sort of the last there. But like, if you...
Not that it's not top priority,
no,
right? But
totally.
it's just, yeah.
But arguably, if you're constipated and you're having painful, like deeper penetration, could that be from constipation?
Yeah.
Yeah. Well, fuck.
I mean, I've seen a few people where they, came in and it was, how originally I think they had come in, like the little blurb that I had gotten sounded like it was painless sex, right? But it was really that they felt this like incredible bowel pressure and discomfort to the point that they couldn't have sex. And it was like, okay, we have to like solve this bowel issue so that, all of these other things can fall into place.
So I thought of something that could work with PBUFFS.
Okay.
So tell me your honest thoughts. Okay.
Yes.
So pelvic babes understand function, strength, and sex.
Wait, I love that so much. Oh, that's so cute. Okay, we're keeping that.
Pelvic babe,
let's go with it.
Understand function, strength, and sex.
Okay. Yes.
All right. So think about it. We'll noodle. We could play around.
Yeah. Yeah. I'm going to put it on a t-shirt. That's my new merch line.
Yes, let's do it. I love a good merch. I also, since I'm moving, I'm going to be doing my podcast studio, and I think I need to get a neon sign. So maybe we can incorporate that for you. Yeah, I know.
I love a good neon sign.
I love it. So tight versus weak. I have danced my whole life. I feel like the common misconception is that all of this stuff is happening. There's some sort of dysfunction. You have a weak pelvic floor. Talk me through that misconception and like the difference and possible like home assessment that you can do to understand more.
Totally. So everything exists on a spectrum, right? really just because you have weakness doesn't mean that it's due to laxity, right? Just as, you can have weakness and tension at the same time. Your pelvic floor needs to be able to move through its full range of motion in order to be able to create that closure around the sphincters to be able to hold up your internal organs. If it's kind of restricted on how much it's doing, when you have, impact from running or jumping or, doing all of these other high intensity activities, it doesn't have the same ability to respond to those stresses. And so, we see stress urinary incontinence in high impact athletes like gymnastics, or gymnasts and dancers and people like that. And it's not because their pelvic floor is weak. It is supremely overworked because they are flipping through the air and they need to be able to hold it all together. But it kind of becomes this okay, we have to get that range of motion back. We actually have to focus on relaxing the pelvic floor first before we can kind of see where it falls within the strength spectrum. And so, this is where going on symptoms alone isn't really going to give me that much. If you just tell me that you're leaking, I'm like, okay, but are you having pain, hip pain, back pain, pain with sex? Are you having constipation? Those things are all going to tell me this is maybe more of a tension issue versus a pure weakness issue, if we're trying to kind of think through it at home. But I mean, you can do kind of a self-assessment where you insert a finger maybe when you're in the shower or something like that, right? And you can press around kind of in a clock formation. And if something feels tight, you have a knot in your shoulder, but it's a muscle down there, or if anything feels tender or anything like that is also information that would kind of lead us to believe, hey, this is a more of a tension issue. You can try doing a Kegel, right? Contracting your muscles. And if you feel like it doesn't really want to go anywhere, or if you can, and then it takes its sweet time relaxing afterwards, that's going to tell me we're more in that upper echelon tension-based pelvic floor dysfunction.
And on the weakness side, what causes weakness outside of, pregnancy, which everyone talks about in relation to pelvic floor dysfunction?
Yeah. I think the biggest one that's kind of relevant to where the conversation is at in society right now is going to be changes related to perimenopause, because estrogen is a very protective hormone, especially when it comes to muscles. And as we start to have that decrease in estrogen, our muscle mass body-wide starts to decrease. And so that can include the pelvic floor muscles. And so if we're having that on top of maybe lifelong not so great pelvic floor habits where we're straining to use the bathroom and we're pushing down onto that pelvic floor, or pushing when we pee, or, like you said, multiple vaginal childbirths, or if you are realizing sometime in your 30s that maybe I have a connective tissue disorder that I didn't realize, all of these things can contribute to the pelvic floor kind of weakening and becoming more lax.
The muscle loss aspect,
Mm-hmm.
are you seeing, perhaps we haven't had access to it for that long already, but with GLP-1 usage, are you starting to see the effects of that in muscle loss in the pelvic floor? Or is that something that could happen? Will we have an epidemic of that?
I think it's a really good question that I really want to see research on, because, certainly I can kind of think of the one or two folks that I've seen in my clinic that, we have noticed kind of just these weird changes, right? But it's not enough of a predictable pattern for me to say one way or the other. But I think because of this, widespread adoption of GLP-1 usage, we really want to make sure that this is something that we're paying attention to.
Yeah, because the people that want to use GLP-1 and then are doing the right things, they're having the nutrition, they're starting the strength training.
Mm-hmm.
I'm thinking pelvic floor therapy should be part of that strength training.
Yeah, it probably should be. And then also, but you also have to think about the gastrointestinal side effects from the GLP-1s, right? If things are slowing down and then they're getting constipated and then they're straining, right? That's also weakening the pelvic floor. So yeah, I think this really needs to be a part of the conversation. And I don't know that it's happening on a wide enough scale yet. I know that there's certainly people that, it's being talked about kind of within my circles, right? In the clinician-based groups that I'm in. But, I think having us as part of the care team would be really important.
Because we always talk about just it takes a while for the science to catch up, right? So what are those preventative things that we can do today to set ourselves up for longevity so that in 10 years when the research comes out, you're like, I'm a beast. I am that pelvic babe that understands function, strength, and sex. So men and women, obviously, that are strength training. And now what's the right approach for like heavy lifting and like keeping the pelvic floor intact?
Yeah. I think a lot of this comes down to pressure management strategies, right? If you're lifting heavy and every time you're lifting heavy, you're, holding your breath and bearing down in order to do that, that might be putting your pelvic floor in a little bit more of a precarious position, right? Typically when I'm working with somebody in an ideal world, I'm assessing their pelvic floor directly as I'm doing this, right? I'm, maybe have them standing while I'm palpating their pelvic floor. And I say, okay, let's see what happens when you do a squat, right? Let's see what happens when you're holding dumbbells and you do a squat. Is there a point at which you start to hold your breath or you're bracing your core weird? And we can change up, the strategy and the cueing that I'm giving them. Maybe they're exhaling on the way up from the squat, making sure they're not closing off their throat. Different things like that. And it's, kind of finding what works for the individual. But if I'm going to give somebody general advice on a podcast, right, it's when in doubt, breathe out. If you are worried that you are doing something weird to your pelvic floor, make sure you're exhaling, because that's going to take a lot of that intra-abdominal pressure off of your pelvic floor.
Yeah. That was another thing that I learned at 39 is that I think I've been breathing incorrectly my whole life.
Most of us have. Yeah.
I practice square breathing and all of that for when I need to downregulate my nervous system, but like not on a general basis that I'm breathing.
Right. Yeah.
And like you're saying, breathing down. I think you had mentioned at some point, like breathe into your butt. Is that something that like, tell me about that?
So your diaphragm and your pelvic floor are supposed to kind of move synergistically with each other. So when you inhale, your diaphragm drops down as your lungs inflate. Your pelvic floor should also kind of go along for the ride, which is, where I kind of get the breathe into your butt from, because I want to make sure that we're having that connection all the way down. So if you kind of imagine on your inhale, your anus opening, your sits bones widening, that's kind of getting that full travel all the way to the basin of the pelvic floor. And then when you exhale, right, the opposite is happening. Everything is kind of moving back up as the diaphragm moves up to deflate the lungs. So, we use that kind of piston motion to our advantage when we're cueing for specific things, whether it's a lift in the gym or a bathroom activity or, sexual activity. If it's something where you're experiencing pain with something, like maybe we have like a certain breathing strategy, or we talk about like relaxing your belly when you're, in a certain position, right? Like there's all kinds of different ways that we can approach that.
Yeah. I think for me personally, because of my dance background, it was always bracing. Like my normal position is to brace and like sort of knit my ribs together. So I'm like in this chronic position. And so like I'll catch myself and it makes like just like those little things that I think like standing and not having your knees locked. For example, for me, like noticing those things, I think a pelvic floor PT can be really useful to say, oh, wow, there are things that I'm doing on a daily basis that are actually adding to the tightness.
Yep, exactly. Yeah. So the locking the knees, the, clenching your abs or the tucking your butt, all of those things can be, really important kind of awareness habits to build. And, sometimes what I'll do with people is I'll have them put like sticky notes next to, their desk or somewhere in their car. And it doesn't even have to say anything. It's just like, oh, when I see that bright pink sticky note, that's my like postural check-in to make sure that I'm not doing any of those kind of previously discussed weird things.
I love that. Or like brushing your teeth, like, or if you oil pull or whatever, like it's like a good amount of time where you could just, okay, I'm noticing we need to fix this.
Yeah, we love a habit stack.
Well, yeah. And it's hard. I think that's a great tip for new moms too, because like when you're holding your infant, like you're like, I would constantly hook my hip.
Yep.
Like you're like leaning into something or like switch your side or something so that you're evening out.
Yes.
Are you seeing a lot more pelvic dysfunction with like egg freezing, IVF, all of that?
I have certainly seen it, right? And there's a few things at play there, right? There's, I think, just from a really basic level, the inherent stress that comes with going through a process like that. I've seen a few people where they've had like worsening urine leakage when they're going through kind of like the egg retrieval process and all of that, because as they're, doing this whole process to make the ovaries stimulate, that's more pressure in the abdominal cavity. That's putting more pressure on your other pelvic organs. There's hormonal changes, there's fluid balance changes. And so it can kind of be one of those things where it maybe, I don't think it's causing a pelvic floor issue to develop, but I think if there was something that was kind of like skirting underneath the surface, this just kind of wipes off that top layer, and now you're like, whoa, hold on.
All of it.
I have to pay attention to this now. Yeah.
Do you think women that are going through that process, that it would behoove them to have pelvic floor, at least like an initial assessment?
Yes, 100%. I mean, I think anybody before they get pregnant, if they think that is something that is on their radar, like they need to know how their body works. They need to know where things are at now so that they can, know what these changes, might look like, and know when things kind of go outside of the realm of what is expected.
Do you have any good resources for pregnancy or for postpartum for women that might not be able to get to a pelvic floor therapist, or whether it's insurance or access?
What do you mean, like this book here?
Perfect.
No, I mean, that's kind of the whole point of Power to the Pelvis, right? Is that it's, the thing that can follow you through the lifespan. It's not like, here is the pregnancy section, here is the postpartum, here is the perimenopause section. It's more symptom-based. And then we discuss like specific strategies and like what might be the contributors to why you have incontinence, in your 20s versus in your late 40s, but it's more action-based so that, people can kind of take ownership of it and start to work on these issues themselves.
Yeah. I love the visuals too of the exercises, because I think that's so helpful.
I really tried to make this a very visual book because it, came from a place of, I'd been educating in social media for a while at this point. I wanted it to be something where people could see what they were supposed to do. And what's actually really cool is this publisher does a lot of like cookbooks and hobby books and things like that. So they're used to making very visual books. They're like, oh yeah, we're going to like have a photographer and like make it a whole thing. So that very much fit with the vibe that I was trying to do.
I love it. It's perfect.
Yeah. Yeah.
The how to heal your pelvic floor.
Exactly.
So let's do a couple of like myth busting things really quick.
Sure.
So if someone said to you, Kegels are the holy grail of pelvic floor support, what would you say?
Boo. No, I mean, it's a piece of the puzzle, right? Not everybody needs to be doing Kegels. They're just a contraction of the pelvic floor. I think everybody should know how to do one, right? But it would be kind of the same thing as saying like bicep curls are the holy grail for all shoulder problems. It's not true, right? It's only a really small portion of what you need to do to have good health around this part of your body.
Yeah. And I feel like that's a whole other thing where if I were to like think about my 20s or even before that, and I heard what a Kegel is, like I thought the idea was so that you are like tighter in sex. Like that was the whole, like it was, there was no, to me, I didn't know what the pelvic floor was. So there was no understanding of like, oh, that's what it is. It's like, oh no, like you want to be tight.
Right. And like, that's patriarchy.
Right. You're like
no, actually. Do you want to be able to enjoy sex? Because and we'll probably get into this at some other point, but like in order for you to have a good orgasm, right, your superficial pelvic floor needs to have good range of motion. And if it's just sitting tight all the time, it's not able to rhythmically contract and relax. It's not able to get good blood flow and good engorgement around the clitoris. And that is impacting your ability to have a good sex life.
Right. I mean, did somehow this administration do this back in time and created the Kegels?
They sent Arnold Kegel back in time.
Jesus. All right. So Kegels, there's a part of it. I mean, in my therapy, it's like, I was learning, okay, to breathe correctly. And then it's sort of like at the end of your breath, that's when you can come back. And then Kegel is the last step to test your tone and all of that, right?
Exactly. Yeah. I mean, it's kind of that like, if we're taking a breath, right? On that inhale, we want to make sure we have that full lengthened range of motion. And then on the exhale, that's when we can do a little bit of that pull up. But when you're done with that exhale, you should be able to come back to neutral, right? Like it's all about kind of, not being stuck at one end or the other of that spectrum.
Don't leave her up there. Bring her down.
No, bring her down. Let her chill.
we touched on this, but leaking after kids is just a part of motherhood.
No. Again, like why, people in other countries are getting help for this, like right off the bat. Like there was something that I saw at one point where, there was a comedian that was traveling and was doing, kind of the typical motherhood, postpartum leakage jokes. And when they were doing international travel, those jokes weren't landing as well because it's not as much of an accepted part of life. Right.
Yeah.
Like this is something that we can absolutely get help for. There's tons of different resources. I mean, there's pelvic PT. And then if you need to go into the upper echelons of talking to a urogynecologist or something like that, like we have these specialties and we have these resources. This is not something that I want you to like still be dealing with 20 years after you've had kids where you've avoided jumping on the trampoline or exercising the way that you want to or whatever it is because of something that was kind of left as a fragment of this, postpartum experience.
Yeah. I am a trampoline park frequenter with 2 little ones.
Yep.
And she holds up pretty well. It's if I cross the threshold and I'm like going zooming into the air like way too high, maybe that will happen. Is it ever like 100%? Like, do I need to? For the most part, I've been told everything is now it's strong. We're looking good. We have to relax when we relax, but. Like, is it ever 100% or is like a little leakage every once in a while? Is that still normal or no? You should have nothing.
I mean, in an ideal world, there should be nothing, right?
Yeah.
I mean, it part of it comes down to like level of bother for that individual person. I'm not going to continue to like push them and like, work through every nitty gritty thing. I feel like it is a drop if I get double bounced at the trampoline park when I've been out there for an hour, But if it's something where it's to the point where it's still bothering that person, then yeah, we're looking at like, specific like plyometric type training, different things to, work on the task specifics of these more advanced activities.
Yeah. I mean, it's definitely advanced. I'm like Michael Jordan.
Yeah.
Up there. So like maybe we just have to, maybe that's the one time that it's okay. Next one. A C-section saves your pelvic floor.
So no, number one, like your pelvic floor still changes during pregnancy because it still has, all of those months of increased pressure on it, which can change how it's able to respond given the situation. Now, what I will say is there might be an argument for, C-sections being more preventative for things like a levator avulsion, right? Which is where the muscle would actually like pull off of the bone of the pelvis, right? Like that's kind of the more severe thing. Yes, if you're not passing a baby through there, like that's not going to happen, or you're not going to, have a perineal tear if you're not, doing that. But to say that it saves your pelvic floor is not true because there's, still other stuff that's happening.
Yeah. Squatting is the same as hovering.
No. So, and this is always so weird to talk about on a podcast where like not everybody's watching this as a visual, but if we're thinking about, hovering as like you're trying to not sit on the toilet and you're like sticking your butt back out over it, that biomechanically is so incredibly different from like a yogi squat or a Slavic squat where you're like butt to the ground, basically, in this very full deep squat. That second position does allow your pelvic floor to fully relax. And that's, why you see squat toilets in other countries where, it's kind of that more optimal emptying position. It's what a squatty potty is trying to do by just bringing your legs up to you while you're on the toilet. But if you're in a hover squat, right, your muscles in your legs and your core and all of this stuff that are helping you try to balance in that position are holding some tension. And that means that your pelvic floor, by extension, is not able to fully relax, which is usually why going in that position, your pee is shooting off to the side or spraying or doing something weird. So it's disrespectful for the people that have to come into the bathroom after you. But also, because you're having to kind of like push past this not relaxed pelvic floor, that can be weakening your pelvic floor over time. So that's why it's really not good to be doing it.
Yeah. I mean, we were just at concerts, we were just talking offline about that. I definitely do a hover and I'm like, oh, but my legs are strong. It's fine. Like, why is it actually okay and not unhealthy to sit on the toilet seat?
So, like, number one, a toilet seat is a hard, non-porous surface. It's designed to repel germs. Your skin is the largest organ in your body. It is designed to like physically, withstand that. Unless you have like a cut on your leg or something, you are fine because your mucosa, your vulva, all of those tissues are not going anywhere near anything, right? So it's
They are,
perfectly
then you
healthy
have an
and fine.
issue. You're
I'm like,
missing it.
I want to know how you're sitting in the first place because that's concerning, right?
Yeah.
Yeah. And do I think the like once a year porta potty squat is going to kill you? No. Right. But I think like in the situations where, I don't know, like at the Xfinity Center where we just were, it's kind of like a slight step up from a porta potty, but actually everybody was like pretty respectful and like the toilet seat was clean. So I just made a little toilet paper nest just to make my brain feel a little bit better. And then I sat. Right. And that's going to allow my pelvic floor to relax better so that I don't get that urge to go to the bathroom again that much sooner because I was not about to miss any of the Hillary Duff concert.
As you shouldn't. What about like the one cheek? Some people do the one cheek on the toilet.
Okay, so the next time you're in the bathroom, I want you to try this. Like, I want you to sit fully in your home, start peeing, and then I want you to pick up a leg, and I want you to tell me that that doesn't do anything to your stream or your pelvic floor, right? Like, it's gonna like change. And so we know that any place where we're not like relaxed, it's going to change what's happening with your pelvic floor muscles, right? We ideally just need to like remain seated for the whole performance. Let your belly relax. Don't push it out. Just like breathe and let it happen. You will be fine. People have been doing this since the invention of the toilet.
Okay, so last question on the peeing.
Yes.
And then we'll get into some therapy questions. So I'm an anxious peer, I think. And so like if we go to the movies, I'll be like, I got to go just in case because I can't, especially if I go with my kids by myself. I'm like, I can't go out to tinkle in the middle of the movie.
Right.
What about peeing just in case?
So listen, I think if you're going to see the Odyssey or something that's like a really long movie, like sure, go just in case once beforehand. But I don't love when people make a habit of it. You should be able to go 2 to 4 hours between trips to the bathroom. And obviously things like the type of fluid that you're drinking, like if you're drinking a lot of coffee or seltzer water or, different things like that might make the bladder contract more and be more irritated, that can certainly be a factor. But if we're repeatedly going just in case, I have to go before I leave the house to go to CVS. I have to go before I do X, Y, and Z. It's kind of training your bladder to not be able to hold as much over time. It shifts kind of the awareness levels of when the bladder feels like it's full. And so it'll start kind of sending you these signals of needing to go at much earlier thresholds. I will typically tell people that the exceptions are like once before bed, before a long car trip, or before and after sex. Before or after. It doesn't have to be both, right? But it's kind of like, those are
It's not gonna feel great. Yeah.
Yeah.
So I'm like, we just finished potty training. My daughters too. But with kids, it's like, you're like, okay, well, let's pee before we do everything. Is there a better way to teach kids about like the fullness of their bladder?
I think, in the early potty training stages, these are itty bitty kids. They have itty bitty bladders. They don't have the same capacity that we do, right? And so, the just in case as we're kind of learning what awareness feels like, that's okay, right? But like once they've kind of solidified in that, then we can start to push it and test it a little bit as they get older so that they're not beholden to this idea that you always have to go just in case beforehand. And it's again, it kind of comes down to that like the more you know about your body, the easier it is to have these conversations, right? Like if you have your kiddo be like aware of like what they drank or how long it's been since the last time they went to the bathroom, like maybe these are conversations that you can have. But also I'm fully going to defer to like the pediatric pelvic floor therapist with this because they are so much cooler than I am when it comes to this stuff. Like I have such a hard time talking to like kiddos about bathroom stuff. And so I think that they would be, that's who I would fully like trust when it comes to figuring out how to push that and change those narratives around the just in cases as the kiddos are getting older.
And how bad is it for us to be like, I think women in general, we push the boundaries of like, I've been working and I haven't peed for like 3 hours.
Yeah.
And
3 hours is fine.
But I've had 16 beverages. And like,
okay, well, yeah.
So what's like an ideal amount of times you should be using the restroom in the day?
I mean, so they usually say like 5 to 7 times in a day during waking hours, or somewhere between 2 to 4 hours between trips to the bathroom, right? So the other thing that we want to avoid, right, are the camel bladders. So I particularly see this with teachers and nurses, like folks who don't have the ability to just like listen to their body's cues and go. And again, I think a lot of that comes down to, these types of professions need more support from administrators to be able to come in and say like, hey, here's a relief for you to go to the bathroom, and not 1 hour into your shift when that doesn't do anything for you. And then you're just kind of going just in case, right? But like thinking about them as a human and not a machine, and letting them be able to, call for an aide or somebody to sit with their class if they have to pee, and not getting shamed for that.
Contributes to tightness or to weakness?
Both, right? Because your bladder is like a balloon, right? And it has like stretch receptors to it. And so if we're repeatedly overstretching the balloon, it kind of decreases our body's awareness of when the bladder is full. And so, we can certainly kind of have issues with overflow incontinence where it's just reached the point where your body's not going to tell you and you're just going to leak. Or it's like the stretch receptors are so floppy and weird that then we're getting, these really frequent trips, or we're doing a lot of anticipatory trips because we don't know what is happening within our bodies.
Yeah. Ooh. I mean, even those little things, it's so useful to just have those details of like day-to-day life.
Yeah, totally.
So in terms of proper prevention and then obviously addressing something when there is dysfunction, so what can women expect from pelvic floor therapy?
Yeah, a lot of talking to start. So, at the practice that I work at, we have people fill out a pretty extensive questionnaire. Not that you have to know all of the answers right in that moment, but I want to start to get people thinking about, what is bringing them in, how specifically their bathroom habits are maybe affecting all of this. Maybe somebody's coming in for a peeing problem and they're not thinking about the bowel movement side of things. I'm going to go ahead and start to queue for some questions there so that I can see, is there maybe constipation driving some of their leakage? Or is there pain that they're not thinking is related to their bowel problem or whatever it is? So when they come in for the appointment, I say, hey, we're probably going to spend the vast majority of this first session talking because I want to make sure that I have a really good understanding and we can start to form hypotheses about what's happening, right? So I'm diving into all of the nitty gritty with them, getting their medical history and all of that. And then from a physical exam standpoint, right, I'm not just looking at the pelvic floor in isolation. The pelvic floor is obviously attached to your core, your back, your legs, all of that. So I'm usually starting with more of an orthopedic type assessment. I'm looking at posture. I'm looking at just like a movement screen, how you walk, how you squat, how you breathe, strength in your hips and back and core. I'll usually do an abdominal assessment, especially if you've had abdominal surgeries, whether it's a C-section or endosurgery or anything like that. I want to kind of see like what your belly feels like. Is it super like rigid and scarred down and tense? Is it feel like it's full of poop? Anything like that. And then depending on what that person is comfortable with, right? Like I will talk them through, this is what the pelvic floor muscle exam entails. We can do as much or as little of it as you're comfortable with. We can push it off to a second, third, or fourth visit. This is information that we're trying to gather, but it's never required. I just want to make sure that I can get as much information as I can so that we're not guessing about what's going on. The pelvic floor assessment is different than your GYN assessment. So there's no stirrups, no speculum, no scary stuff. It's a single digit, so single finger glove lubrication. And that is where we're basically going into at max, like the second knuckle of your finger to map out what's happening with those muscles that are kind of in that bowl of the pelvic floor. I'm looking for tension, right? I'm looking for anything that reproduces like tenderness or pain or a feeling of having to pee. I'm able to assess the muscle function directly. So I'll say, okay, try to do a Kegel. Try to hold that Kegel for 10 seconds. Try to quickly contract and relax it. Is it relaxing all the way? What happens when you try to push, like you're trying to have a bowel movement? Like we're having you do all of these little teeny tiny movements so that I can see where things are falling through the gaps. And so we can start to make a treatment plan of, how this all fits together and how that aligns with your goals.
So once you have this assessment and you create your treatment plan, so I, walking into pelvic floor PT for the first time, I had no idea that there was more like myofascial release of tissues that are not what I would consider, like, I thought it was only focused there. So you're saying everything is interconnected, but just like
Yes.
even my upper back, like having a release of the upper back and the internal massage, which sounds uncomfortable and maybe a little, I don't know, just different to women, because
Totally.
I feel like there's a lot of trauma or confusion around getting, to your point at the OB, getting your cervical exam with a pap smear, and how incredible the internal massage can actually be. Can you talk to us a little bit about what that's called and how that helps to treat the pelvic floor muscles?
Yeah. So, I think there's been a few people that I've heard say this phrase, but, the idea of calling pelvic floor therapy orthopedics in a cave, it's, a lot of it is so similar to what we do when we're treating a shoulder or a hip or something like that, right? Like, these are muscles, this is fascia, this is nerves, all of this stuff is the same. It's just we have to be like respectful of the fact that we're working in an area that A, people don't have enough knowledge about. B, a lot of people are coming in and they've had, some kind of trauma in their life, whether it's medical trauma, sexual trauma, whatever the case may be. Like, we have to approach this from a respectful standpoint so that we're not creating more trauma for that person. The internal massage, right, is something that similar to if you have a knot in your shoulder or something like that, you can gently apply pressure to a muscle that is reproducing some kind of symptom for you, doing some deep breathing exercises, having you like move a leg around or do different things like that in order to get this muscle to relax. And that can be really, really impactful for addressing the associated hip pain, back pain, or pain with sex, or, this like tension based urinary dysfunction, whatever it is. And that can be done either vaginally or rectally, depending on the person's anatomy, what they're specifically coming in for, but and then it's also something that we can teach people how to do at home, either with their own hands or using different tools like a pelvic wand or a dilator or something like that to give them ownership of it and to be able to like have them be able to work on some of these things in between our sessions.
For me, when I've had the internal massage, I didn't realize how initially you could feel the tension, like you were saying, the knot in your back, it felt like knives. And I was like, oh, that's the knot. Like, that's where we need to alleviate the pressure and the pain. And going over time to feel how it's released has been incredible.
Yeah.
And like, I
it's
noticed
really
that
cool.
like noticing my bowel movements are so much easier. And then just like, I will also say like orgasms are so much easier, but also like more powerful.
Yes, exactly. So that's kind of that harkens back to what we were talking about before, where like if the muscles are too tense, like your pelvic floor needs to be able to rhythmically contract with an orgasm. If it doesn't have the range of motion to do that, if it doesn't have the blood flow to do that, it's not going to be as good. And so once we start doing this internal massage, doing that myofascial release work, it's allowing for more of that blood flow and range of motion to happen. And you're right, like it should be, subsequent times as we're going in over time, like there should be less baseline tension. It shouldn't be that same knot comes back. That might be an indication there's something else somewhere in the body that might be contributing to why it keeps coming back.
Yeah. And I think, obviously women are constantly thinking about cost and insurance and all of these different things. But can you also talk just more about frequency and then, once you get to a certain point of maintenance, like you were saying, like how does that work with, sort of supplementing that at home?
Yeah. So I think, when we're first getting started in pelvic floor therapy, I want typically for the sessions to be more frequent because we're trying to get your body out of whatever stuck pattern that it's been in, right? So you need to apply a stimulus more regularly in order to enact change. And that can be in a combination of in-person sessions. I'm giving you homework, whether that's like stretches and breathing exercises or core exercises, or starting to incorporate using a pelvic wand. And as your body kind of starts to get the the gist of what you're asking it, then we can start to taper some of those sessions. Maybe we go to every other week and we see if things are still holding at the same, degree of efficacy. And then eventually you get to the point where we say, okay, like maybe I haven't seen you for a month or 6 weeks and things are still holding on. And maybe we say, okay, we talk about this, like what it means for the individual person. Like there are certainly people where they want to have kind of a maintenance session where they're coming in every couple of months to check in on what's happening with their pelvic floor. For some people, it's every 6 months. For some people, they're like, I think I got it. We're good. And I have my tools and I'll reach back out if anything ever changes. I want to create a plan of care that supports whatever is going to work for that individual person. But, it's just kind of this general idea of like start more frequently and then taper. And the duration of that care is going to vary widely. There's some people where, I'll see them for 6 to 8 visits and we're like, okay, we're done. Right. There's some people that I will see, because I also tend to work with people with more, complexity, right? They maybe have other concurrent medical conditions that are contributing to this. Maybe they have Ehlers-Danlos or they have something else where they need kind of this more prolonged care. So I'll have people that are kind of in my care for a much longer period of time.
Yeah, I now go once every month. I had gone for like 6 months for like probably every 2 weeks. And I mentioned this to you, but I'm still figuring out how to use the pelvic wand at home. I think that the first time I used it, I was like, oh, that is too high. That is my cervix. It's not where we're going. So we're fishing that out. We're working on it. So I might need your help. And
yeah, totally.
Like, I think understanding that you don't need to go too deep. It's
right. Well, and I kind of say like the pelvic wand, right? The whole idea is that it's supposed to be, reproducing either what the therapist is doing in session with their finger or, acting as an extension of your arm at home. But that's where I kind of use the like, this is the amount that should go in, right? And usually like on the Intimate Rose wand, there's like a little flower decal that's basically right at that point. So you can use that as a little bit of a guide to say, okay, like this is where I need to be, give or take.
Because, it's this long. It's
right. It's a handle. It's mostly handle.
And don't use it as a vibrator because my pelvic floor therapist said she had a client try to use it, which I don't know why you would want to because it's like this thin. But hey, to each their own.
Yeah, there are pelvic wands that vibrate, right? And the intent with that is that for certain people, like low level vibration can help to facilitate muscle relaxation. But like, I wouldn't use that to try to like make an orgasm happen. Now, by contrast, there is a device called the Kiwi that is this kind of little nugget shaped device that's has like kind of a shallow nub that you can work on kind of the initial layer of penetration. And it kind of has this like piece for clitoral stimulation at the same time. So it's this really cool device that's a bridge between working on your pelvic floor and integrating like sexual.
I was like, did I see that in Provincetown? There was one that was like a sucker.
That's so funny. No, this is like it's green and it literally looks like a little kiwi bird. Yeah.
Maybe a different one.
Maybe a different one. They get into some really fun stuff down there.
Like how, in terms of other modalities that you have folks bring in. So I started to do some chiropractor work as well because I have scoliosis from dance as well. So for me, that's kind of been like my perfect support. Are there any other modalities that you typically refer clients to?
So, there's certainly within the PT world, I will, I have my like TMJ person that like, if this person has a lot of TMJ issues, I am sending them to Victoria because she is just like the GOAT when it comes to this stuff, or if somebody, if somebody has that more specialized knowledge, I want to make sure that I have the best team possible for them. I'm really frequently working with dietitians to make sure that people are getting really good information there, and I think also like a good women's health provider that can help with medication management is a really important person to have on the team. Mental health can be really great, whether that's just, generally speaking, like would love everybody to have a therapist, right? But especially when we're dealing with sexual pain, sexual trauma, if they're open to working with a sex therapist, that is also always high on my list of recommendations as well.
The mental health because of the nervous system and how that plays a role.
Yeah.
So talk
definitely.
to me a little bit about that, like vagus nerve, nervous system. Like obviously, my mind is going towards, okay, it helps you relax everything, but how does that play a role?
Yeah, so, everything is controlled by your nervous system, right? That's not to say like it's all in your head, but like it's all coming from your brain that is then going through your nervous system. And so, we're all, every discipline that you see should be respectful of that, but having, mental health providers as kind of like a quarterback to help to process anything that's coming up, because we are doing things that are, different, right, than your average PT session. I think that it's really important from that perspective. And then also, we talk a lot about how stress and anxiety are all, all of that like autonomic nervous system stuff is all fueling what's happening with your pelvic floor. If we're in a heightened state of stress and anxiety, that can be certainly causing your pelvic floor to clench up or be a significant contributor there. And so, I want to make sure that we're being respectful of that and looking at that as a potential driver there as well.
In your opinion, do you think we store trauma in like our hips and our jaw? And like, do you feel like that's true in what you see and what you release?
Here's the thing, like, is there a research study that will point to that? No. I have had multiple people on my table where I'm doing a psoas release or I'm doing a pelvic floor release where they will like straight up start crying as that muscle releases, right? Like there is certainly something there, some kind of integration with the nervous system, whether that's, trauma or something else. Like I think it's important to recognize that like that is a thing that happens, and because these are areas of our body that we have, so much like societal weirdness around, it makes sense that the funky stuff is going to come up sometimes.
Like, can we stop calling it more woo-woo stuff? Like, then fine, walk around with your tight pelvic floor and like get on with your incontinence. Like it's okay to have multiple providers that can work together. And I think it's that beautiful balance that can make you have like full body health. Like pelvic floor is full body health.
Yes, definitely.
One last question about care is just, I know you've talked about dry needling before, abdominal massage. Like what are some of those other things that women can expect as a possibility in their PT?
Yeah. So, so certainly dry needling, right, is something that I do a lot in my practice. It's basically where you use, the same types of needles that you use in acupuncture. So those little teeny monofilament needles, not directly in the pelvic floor necessarily, but that can be done. But usually, I'll use it kind of in the areas around, like we can use it on C-section scars. We can use it in the inner thighs, or we can use it on the, like neck and upper traps to kind of help to facilitate that relaxation there to then impact what's happening with the pelvic floor. Myofascial release kind of in the same vein of, the allowing the muscle structures around the pelvis and around the rest of the body to kind of unwind and have their time where they're not being like forced into submission, right? And how that kind of plays a role with what's happening with the pelvic floor. Other modalities that maybe we're seeing, I don't know, sometimes I'll use cupping, sometimes I'll use like other instruments to assist. So like those kind of Graston tools, not to like use like, a specific brand, but there's those kind of like metal scrapey tools, like jade tools, they look like gua sha type things.
Yeah.
I'll teach people how to use different implements like foam rolling and like ways of doing other types of manual manipulation to themselves. But again, like what you're going to specifically have recommended to you, it's going to be completely different for somebody that's coming in with a straight up weakness based incontinence issue versus a complex pelvic pain, chronic UTI. I don't know. Like it's all going to be different.
Is there any emerging research that you're seeing that you're sort of excited about in terms of care or what we're learning about the pelvic floor?
That's really interesting. I think, the stuff that I'm seeing, maybe not necessarily in specific clinical research, but I'm seeing a lot of folks who are doing more for the like prolapse community in terms of different wearables that they can use to help to provide support, whether it's like support, literally like supportive underwear versus like, you know, insertable devices, different things like that. I feel like I've seen a lot of talk and a lot of discussion about different things that are coming out there, which is great because I feel like it was previously all kind of like, you know, pessary or surgery or, you know, hopefully pelvic PT will help you. And it's nice to kind of see these more conservative options woven in to where maybe they're working in adjunct alongside PT.
And so for our listeners, prolapse is when your pelvic floor starts to fail and your organs are at risk. What's a little bit more of, not in layman's terms?
Yeah. So your pelvic organs, right? So your uterus, your bladder, your bowel, they're all held up by kind of two major things, your pelvic floor muscles and your ligaments. And so prolapse is typically happening when one or both of those things are not doing their job super well. And so that can mean that everything either like falls downward. So like you can see like the uterus or the cervix kind of protruding from the vagina, or from a top or bottom perspective, either like the bladder kind of pushing into the vaginal canal or the bowel pushing up into the vaginal canal. And so, you know, previously, like I said, like pessary and surgery were kind of your two major options. And a pessary is kind of like an orthotic for your vagina, which is great. Love a good orthotic. And, you know, but it's, you know, it's cool to see kind of these more like mid-range options, because this can be really uncomfortable for people. It can cause, you know, difficulty going to the bathroom. It can cause, you know, like pelvic heaviness. It can contribute to back pain, different things like that. So, you know, it can be one of those things that's, just another thing that's kind of taking away from people's quality of life if they don't know what's driving it.
Just like a easier access to support versus having to go down the path of surgery and all of that. Switching gears quickly to sex, how many women do you think are actually having great sex?
You know, like I wish I could say it was all of them, and we know it's not all of them. I don't know. I mean, I feel like it is more common than it used to be to have people have like good health literacy around what their body needs in order to feel good during sex, you know, and I think too, like the more that these conversations are happening in public, whether it's on social media, whatever, it's like, it's not only the women that are seeing it, but it's also their partners who are seeing like, maybe I need to be communicating better about X, Y, and Z. But I always think that the number could and should be higher because of the society.
Right. Like, I don't think most of us know like what great sex could be.
No.
Right.
No. This is, you know, when it comes down to like what are the touch points when like people are younger, like I'm like, when you turn 16, I'm just going to give you Come As You Are by Emily Nagoski. And I'm going to like use that as like an entry point to learning about your body and what things should feel like.
Well, so tell me, do you also help or do you pass the torch for women to understand more of like the soft tissues and like the clitoris and all of that? Is that under your purview?
Yeah, no, I mean, it definitely is. I mean, I think, am I the be all end all of it? No, right? Like that's where like sex therapists are awesome and like, you know, like all these other different resources. But I am also pulling out the hand mirror, right? And I'm like showing them, hey, this is where these parts of your body are. You know, when I say like, hey, I'm going to look at your clitoral hood, like most of the time people are going to look at me like, what's a hood? So it's nice to be able to do that with them and like give that shared ownership about what's happening with their bodies and talk about how all of these pieces play into, you know, the sexual experience. And I think that the more information and the more ownership that we give there, the better off folks are going to be.
If you had to say to your best friend or your sister, okay, you're going to have amazing fucking sex. I'm just learning about this Lionsgate thing that's happening, the portal. So I'm like, everyone's going to be manifesting. So this gal is manifesting great sex, best orgasms of her life. What are your suggestions to her to sort of get on that path?
Oh my gosh. Ooh. All right. Let's see. I think get out of whatever the typical way is that you get yourself off, right? I think a lot of people get into this like, okay, this is my like guaranteed way and this is how it always happens. I think part of having a better sex life is being able to explore, in your self-pleasure sessions, different positions, different modalities, go analog, use a different vibrator, like you want to be curious with your body. I think that's the biggest thing, is just, approaching everything with an air of curiosity.
And so the pelvic floor playing into that, as you were saying, your orgasms will be better if you relax.
Yeah,
Why
I mean,
is
there's
that?
so much. Well, and because if, I feel like the vast majority of people, if they've experienced orgasms with a partner, it's like a tension-based thing. They're like, oh, yeah, pulling. And like, you can get an orgasm that way, but it's not going to be as fulfilling as like one that comes from a place of like letting go and relaxing and getting this like full, wave of muscle activation that comes from your pelvic floor being more relaxed when it happens.
Yeah. And then externally, what's the clitoral hood for our friends that are listening?
Yeah. So the clitoral hood is basically, I mean, if you kind of think about it like a hoodie on a jacket, right? The clitoris, first of all, is not just the bean, right? It actually has legs and crura that extend down and kind of interdigitate with the superficial layer of the pelvic floor muscles. But the clitoral hood is kind of this like piece of connective tissue or skin that sits over top of the top of the clitoris. And that sliding and gliding and moving back and forth can help to create stimulation and blood flow around the clitoris, and that can help to contribute to arousal and orgasm.
And so what issues can arise with the hood?
So it can get stuck, right? So, we can have restrictions around it. Like some people will sometimes have to have like the adhesions removed so that the clitoral hood is able to slide. Sometimes it can kind of almost like, what is the word I'm looking for? Like not scar down, but like as you have those hormonal changes, like it can shrink a little bit. And
Like your
so,
labia?
yeah, like
Does
your
it shrink with
labia.
the labia? Like in
Yeah,
perimenopause? Oh,
because
sweet
it's
Jesus.
all, it's because it's all in there together.
I was like, I don't really mind with the labia shrinking, but the clitoris shrinking could be an issue.
Yeah, no, and I know folks that are using topical estrogen where they're putting it specifically like around the clitoral hood, and then they're using that like alongside like doing like self mobilizations to the hood in order to kind of maintain the tissue itself and maintain that mobility or get that mobility back if it feels like it's starting to go away.
Most women don't have a clue about the clitoral hood. So if you have these adhesions, is it because of lack of use?
Not necessarily, no. It can certainly be, something where, stuff can like build up under the hood and can then, like kind of
Lovely.
get stiff. I know. And I'm like, how do I say this in a nice way? Stuff can get under there and build up and get restricted. So, sometimes even what I'll have people do is I'll have, if you have like a removable shower head, is to literally like run hot water over the area in the shower and kind of like try to get up under the hood and like do a little bit of like self mobilization yourself. So it doesn't have to be like you're using some kind of fancy cream. It can literally just be, let's pay attention to how this is moving with like the warm water in the shower and all of that.
Yeah. Our dear friend Kathy Cates, when she
Yeah.
examined me when I was still breastfeeding, she was like, "Oh, your like tissue's actually really white." And so, obviously my estrogen was super low at that time. So like tons of dryness, all of that. Like, do you have a favorite lotion, like maybe a cleaner product that you think women should utilize, not just for if they're breastfeeding or postpartum, but just like in general?
I mean, there's certainly like the Kindra is the one that we use a lot in the clinic, and it's like a vaginal vulvar moisturizer that's got like really clean ingredients and tends to do really well with folks. I don't want people like using Aquaphor or something like that, right? Like this is not where like your regular beauty products go. Like you want something that is a little bit more specially curated.
Yeah.
So yes, I would say like that would probably be my go-to.
Okay. And then just like what role does sexual health and orgasm play in longevity?
I am a firm believer that sex is an ADL, right? An activity of daily living in the same way that like your your mobility and these other, your ability to brush your teeth and your ability to have sex, like they are hand in hand just as important to me. So, if we have a good sex life, that is helping with blood flow kind of around the body, right? That's good for heart health. That's good for all of these things. So I think it's really important that, everybody's going to have different levels of value that they place on it. But I think sexual function and paying attention to it as we get older is so incredibly important.
If you had to shout one thing from the rooftops about pelvic floor health to women, what would it be?
Oh my gosh. Relax your belly and take a deep breath. I don't need you thinking about your pelvic floor 100 times a day, right? I need you to think about all of the surrounding areas, and the biggest, heaviest hitter is if we can just not be sucking it in all the time. That can play such a huge role.
For so many different reasons.
Mm-hmm.
All right, quick fire round for you. What is one wellness or beauty trend that you've found on social media that you've actually leaned into?
Oh my gosh, just the idea of a skincare routine in general. Like pre-pandemic, I was still using the St. Ives apricot scrub. So
no, girlfriend, I used it religiously for, 10 years, but now I'm like, do I have to laser this shit off? Like I have all these broken capillaries.
Right. I mean, that's the thing is over the last 6 years, I've gone through this whole journey with it. And this is there's no makeup on my face other than a little bit of mascara right now, which is something I never would have done.
Okay. So what are you using? What's your secret?
Right now, I'm just using Typology products.
Are you using those drops?
Yeah.
We love it.
Yeah, I've fully committed to them. I'm hey, sponsor me because I spend too much money at your company.
Well, let's work on it. I love it. Do you have a favorite vibrator currently?
Ooh, I mean, the Rose is always a good crowd pleaser and a good crowd favorite.
That's the sucker, or that's not the Kiwi?
No,
that's
not the Kiwi. No, it's the one that it looks like a little rose. Yeah, it's got the little filigree there. Yeah.
I'm going to have to text this to you because I'm not going to be able to put it in the show notes, but I have to show you the thing that I saw in P-Town that was literal. Yes. It was quite frightening. Yes. I mean, can you see that?
Oh, goodness. Well, okay. So, but also I read a fair amount of smutty books. And so that's something I feel you would see at in a monster romance or something.
It's called a creature cock.
Yeah,
so you're interested. Okay. Is there a favorite pelvic floor product? Again, it's not a one size fits all, but is there something that if someone wanted to just start to learn about their bodies outside of power to the pelvis, is there anything else you think?
Good question. That's kind of broadly applicable. I mean, I feel if it's something where you want to kind of feel what's going on with your pelvic floor muscles, it's not necessarily a tool. It's just doing a self-assessment, right? Being able to actually explore your body, press on things, that is going to be the best tool in your toolbox.
Yeah. And I've mentioned this before on the podcast, but the show off campus is really useful to do that.
Yes, definitely.
Last thing you asked AI, whatever tool you use.
Oh gosh, I don't use AI, but I will say the last thing I Googled was I'm trying to put in a little free library, and so I'm making sure there's no specific rules in Boston about how to do that.
Love it. It's awesome. So on that note, maybe a book or a resource you'd like to extend to women. And it doesn't have to be health related. If there's an amazing smut book you're reading or something.
Oh man.
You're actually.
I'm well, let me just go through my whole library right now. No, but I mean, I think, if we're thinking about books that are going to, start conversations, Want by Gillian Anderson is really cool. It's a bunch of little vignettes of women's sexual fantasies. That one is a book that I haven't gotten through the whole thing, but it's kind of one of those you can just open up to a page and be what am I reading tonight?
Love.
And that might be a more accessible way for people to start to explore that a little.
Cool. I love it. Before we go, where can people find you, the book, your practice, all of the great things?
So online, I am at the Pelvic Dance Floor on both Instagram and TikTok. And my website is thepelvicdancefloor.com. If you're looking for a pelvic PT and you're in the Boston area, I work at Wellist Integrative Health, which is just wellisthealth.com. Yeah.
I love it. Thank you so much for being here.
Thank you so much for having me. This was so much fun.
It was awesome. Okay, what an exceptional episode. We could have spoken for hours and hours about this. The net for me is really every woman, every girl should be getting a pelvic floor assessment. It doesn't matter if you have kids, want to have kids. We should really be establishing a baseline when we're young so that we know our anatomy. We have body autonomy, understanding, literacy, and can actually make informed decisions about our bodies. Why, again, am I 39 learning all of this? We have to pay it forward. If you love this episode, please leave us a comment, rate, review. Make sure you are subscribed to Off With Your Coat wherever you listen so you get all of our great updates. And be sure to follow at GenWell Official on Instagram so that we can stay ahead of all of the new women's health updates that are coming out. Thanks so much, guys. See you next week.